Welcome to The Scope with Dr. K. I'm Dr. Kaczynski. We're going to open the show today, as we always do, by stating that the goal of this show is to present you with a broad scope of value-based care issues, mainly involving the field of gastroenterology, but also outside of GI as well. We are moving back today to the provider side. Our guest is Dr. Helen Burstin, the CEO of the Council of Medical Specialty Societies, CMSS, a coalition of more than 50 specialty societies representing more than 800,000 physicians. To use Helen's own words, CMSS is an organization of organizations. As the National Organization of Specialty Societies, it advances the expertise and collective voice of medical specialty societies in support of physicians and, more importantly, the patients they serve. Representing every specialty from primary care to surgery, yes, primary care is a specialty, CMSS addresses critical issues across the specialties through shared learning and innovation, convening, collaboration, and collective action. I listened to Dr. Burstin at PTAC a few weeks ago, and I've met her in the past at CMSS meetings. Her career has been heavily focused on quality. She formerly served as the Chief Scientific Officer of NQF, the National Quality Forum. Prior to joining NQF, she was the Director of the Center for Primary Care Prevention and Clinical Partnerships at AHRQ, the Agency for Healthcare Research and Quality. Prior to that, she was an assistant professor at Harvard Medical School and served as Director of Quality Measurement at the Brigham. She clearly has a passion for quality. Her formal training is in internal medicine, plus she did a fellowship in health services research at Harvard. She's a clinical professor of medicine at George Washington University School of Medicine. Finally, she's been an author of more than 100 articles and book chapters on quality, safety, equity, and measurement. Welcome to the show, Helen.
My pleasure. Boy, that was a long intro. I need to get a shorter bio.
No. It takes a lifetime to build a bio like that, and it deserves to be stated at the beginning. So my listeners all know that I like to begin the podcast by allowing the guests to tell us a little about themselves in their own words. Tell us about yourself. How did you get to where you are today?
It's a great question. And I think it's often that old quote by John Lennon of life is what happens while you're busy making other plans. And I think in many ways, particularly for somebody who got engaged in quality and equity really early, there were no chief quality officers or things like that when I was out there. So it was a pretty nonlinear road, but I always knew that I was interested, particularly in access issues and issues of equity. I served as the national president of the American Medical Student Association for a year in medical school, and I knew I wanted to train in primary care internal medicine. And I always sort of envisioned that I'd be working in a community health center, doing advocacy work and really driving equity and quality. So that was kind of how it started. And I think really over time, things came to me in ways that I think, as I often advise a lot of mentees, is just I think I was willing to take opportunities that came my way, even if they didn't seem linear in the path to being a professor at Harvard Medical School, right? So I think I, had the opportunity, for example, to, as part of my primary care internal medicine residency, to practice in an FQHC. So getting to actually practice there while I was a resident. And then even when I went to the Brigham and stayed on as faculty, I stayed at that community health center in Dorchester, Massachusetts for 10 years on Thursday nights, because I was so passionate about understanding what happens in a community and really understanding what is different about a true system like a community health center that led to better outcomes for patients who are often the most marginalized.
Well, you and I are similar to the same vintage. I think you're younger than me, though. But I was impressed by the fact that immediately after your residency, you completed a fellowship in health services research. Now, listening to you, I think I'm understanding it. But this was really not typical of people trained in our generation.
It was fascinating. And I'll tell you, it was a story. It was exactly the point I was trying to make earlier. So when I was a junior resident at Boston City, we had a nursing strike. For those of you of the right vintage, Boston City used to call their ER the accident floor, believe it or not, from the old days of the UK. But we had a nursing strike, and so we had to treat and transfer all of our patients out of the hospital ED to other hospitals in the city. And it became very apparent that the patients I was packaging to send for admission somewhere else were bouncing right back the next day. They weren't admitted, even though we packaged them. And so my chief resident at the time, Jeffrey Samet, a brilliant general internist and addictionologist, the chief residents at Boston City did their fellowship and came back. And he had just finished his fellowship at MGH, the same Harvard General Medicine fellowship. And I was complaining that my patients were bouncing back. And he said, well, we should study it. And I was like, what do you mean? Like, what do we do? And we did. I got into every record room in the city of Boston and reviewed every record of every patient we treated and transferred. And it was my first paper in the Annals of Emergency Medicine. And it showed that patients of equal severity who were not admitted were homeless and IV drug users. And it was really interesting because that was sort of our impression. And when I presented it to the nurse managers when they were kind of back, the chief nurse who was there through the strike said, well, I could have told you that. I'd call report on these patients, and the nurse on the other end would say, do they smell? Like they just didn't know how to take care of our patients. And it showed. But because of that, you know, I kind of got the idea that I could be a better advocate with a quantitative skill set. And I had a week left to apply for that fellowship. Jeffrey told me to apply for the fellowship, and then I got in. So it was sort of one of those moments of like, should I take this path? Well, why not? What do I have to lose? If I don't get in, I don't get in. And then I did. And for me, also being a sort of, working class kid, grew up in Brooklyn, immigrant parents, getting a free MPH at Harvard was kind of a sweet deal.
Yeah. But you had already earned it with what you had done already. But I'm still impressed by the fact that, I was trained to take care of one patient at a time.
Yeah,
I never heard the word population health in the
yeah,
80s and 90s. I mean,
right.
it wasn't a term, it was your single patient. You went from patient to patient, but you had a vision early. You had a vision early in your career to use data to help you understand what was happening in populations of people. That's truly innovative for the period of time in which we learned.
It is and it isn't, because I do think there was a whole movement in the primary care space around community-oriented primary care that I think had more of those early population threads than we give it credit.
Yeah. Sonar, the company I founded 10
Yeah,
years ago, it started similarly with a quantitative view of IBD patients. I went into that not really knowing what I was going to find out, but the single factor that in the 17% of the patients who get admitted to a hospital for IBD, in the 30 days before those hospital admissions, in 2/3 of the patients, there were no CPT codes.
yeah.
That was the aha moment. So, give a good quantitative thinking doctor a set of data, and
Totally.
we can come up with some solutions. That's
Absolutely.
that.
And I think that's what's been missing in equity so long, is we haven't had a really good set of data to wrap our arms around.
Well, that's what I want to pivot to right
Yep.
now. So you've also been a pioneer in health equity. You led the first report on national healthcare disparities 20 years ago. So tell us about this.
Yeah, so it's interesting. You specifically asked about how I developed this passion, and I think it goes a couple of different ways. I think some of it is innate to who you are as a person, and I think some of that is sort of your experiences academically. So for me, at the deeper level, I mentioned my parents are both immigrants, but they're also both Holocaust survivors.
Hmm.
So I think I very much grew up in this world where I saw way too many people, all their friends and others, who had been treated as less than human. And I just really, from a very young age, was just deeply passionate about ensuring that everyone gets treated with the respect that they deserve. So that was built into me in my core from a very early age. But then, as I mentioned, training in a public hospital and a community health center, seeing way too many patients who present late because they haven't had access, or they don't have insurance, or they don't speak English. And so I think all those experiences came together when I was at the Brigham. I was part of a very large study called the Harvard Medical Practice Study, sort of one of the seminal studies looking at adverse events and malpractice. And I walked in and I said, I want to do work on equity. And they allowed me to use this extraordinary data set. And we showed, for example, that uninsured patients were 2.5-fold more likely to have substandard care. So again, I was really taken with the idea that by having a quantitative data set in that way, you could advocate in a way that you can't just do by saying, hey, we really should have better access. And I have to say, between both those experiences of working on that study, putting out these clear evidence that patients who didn't speak English or who are uninsured, et cetera, didn't have equal care. And then the disparities report, when we systematically demonstrated across a huge variety of indicators that there were known and persistent inequities, I really thought it was going to change everything. I really thought putting this information out there would be a game changer, and you could no longer look at quality without considering equity. And I was wrong. And I've now sort of taken a much broader view, but it's taken too long, I think, for the system writ large to finally say, we just can't look at quality without looking at equity. And I've continued to make that sort of cornerstone of my work all the way through, including the work we're doing right now. Actually, CMSS is involved with the Doris Duke Foundation and the National Academy of Medicine of looking at how can we remove the inappropriate use of race as a biologic construct in our clinical guidelines and algorithms. This is just an extension of that same focus on equity, but it has huge clinical implications when patients who are Black are denied care because of an algorithm that inappropriately assigns their race rather than an actual clinical or social construct.
Well, Helen, keep focusing, keep using your passion. I hear it at PTech all the time. It's amazing though that, well, we have had incremental change. We haven't had revolutionary change.
Oh,
We've
yeah,
had incremental change, and
yep,
sometimes incremental change is the most long
it's
lasting, but
okay.
we need
Yeah,
more. We
we
need
need
more.
more. And I've always wanted to see, and I wrote a paper on this about 4 or 5 years ago in the Annals of Internal Medicine about how ultimately we have to weave equity into the fabric of quality measurement. And I'll continue to scream it. But hopefully a big part of this, and we'll talk about this soon, but a big part of this is not having the right data systems.
Yeah.
And hopefully as the data systems get better, we'll have the ability to just look at things in totally new ways. We just had a meeting, for example, on this race and algorithms work with some of the leading NIH institutes. And one of the NIH directors said, we're probably, I don't know, 5 to 10 years from having everybody's genome in their EHR, right? Just that's mind-boggling, right? So if you actually start to look at these new kinds of data we've never been able to see before, can recognize that what we're seeing and labeling as a race difference in equity is probably structural racism or one of these other
Yeah.
social drivers we haven't been able to measure yet.
Yeah. Yeah. Well, you know what? Let's pivot again here. You know, your major work that you're known for is on quality. And so let's talk about this. I want you to tell the listeners how you define quality and how we measure it. Is it process? Is it outcome? What
Yeah.
is the Helen Burstin thoughts on this?
Oh, it's such a good question. I mean, for me, quality is ensuring that every patient gets the right care at the right time, the appropriate level of services with the best possible outcomes. So when you think about is it process or outcomes, I'm a believer it's both. I think we need to measure whatever is appropriate. And I think for me, it's just that if we're going to use process measures, they have to at least be proximal to the outcome. So, for example, when I was at NQF, our renal committee had a big debate over a measure that looked at whether nephrologists were referring patients with CKD to vascular surgery, right? And it became a measure in that way, but essentially it was a checkbox, right? Nephrologist checks the box, patient referred to vascular. But we found the vast majority, so much of the time, the patient was referred but never seen. And
Oh,
so the
wow.
measure got changed to, did the patient get seen by vascular for early vascular access? And that is different because it isn't just the act of a single physician referring somebody, but it then implies the need for the system change to make sure you're actually getting seen. That's not just the doc, right? That's got to be a whole system and a fabric of care and that interaction between specialists and primary care that, I think we're going to talk more about. But I actually even, this some people may not agree, but I actually think we also need to consider structural measures. They kind of came out of fashion and they're slightly back. CMS is now really interested in structural measures again. They may not work for the long term because eventually people figure out, like, yes, we did all this and they move on. But I still think it's a good way to get at a stepping stone towards harder outcome measures. Things like, of course, we want patient-reported outcome measures. It's really still hard to do. But if you had a structural measure and a process measure that got you along that path, I'm all for just, again, as you just said, incremental change towards getting to the better measures. But at the same time, really, really importantly, we have to get rid of those measures that don't add value.
Yes.
We have to get, for so many years, measures got constructed because the data were available, not because those measures were important. And so I think we just have to say they don't drive improvement. They just they're not even useful for accountability. Remember having an argument at one point when we eliminated one of the earliest HEDIS measures when I was at NQF, which was did your throat get swabbed if you had strep? And it was like that in and of itself wasn't enough anymore. That measure was like NQF 0001, right? Enough. It should really be, did you get a strep test? Did you get treated appropriately based on the results? Why are we just saying
Yeah.
you did the process? To me, that was
Right.
too distal. But I think we can move closer to the measures that matter. But given all the burnout we see among clinicians and others, don't make them collect stupid stuff
Yeah.
just to check a box. Get rid of those. Let them focus on measures that, as I often used to say when I was head of quality at the Brigham, we would give our clinicians their scores, like all your preventive scores across primary care. We labeled everybody A to Z so nobody could see their scores on the graph. And within 5 minutes, Larry, they all wanted to see each other's scores because they wanted to know, like, how did you get to 90% pap smears? What are you doing? And to me, that's often the test. Will a clinician want to pass that, look to see how others do, to see if they can actually drive improvement with that measure? Because otherwise, it just feels like busy work. And our clinicians are busy enough doing clinical care. I don't want them burdened with things that are not adding value.
Oh, you've touched on so many topics here. I'm going to take a little break here. If you've just tuned in, you're listening to The Scope with Dr. K. Our guest today is Dr. Helen Burstin, CEO of the Council of Medical Specialty Societies. Helen, you touched on a couple of things here that I want to make sure we discuss. I love where you've gone with this, and I listened to you at PTAC as well. These measures have to be meaningful. We've got gastroenterologists who are checking boxes for smoking cessation, just so that they can satisfy MIPS measures, and because there's not that many GI measures available. So it comes down to the question, how do we do this? So you've really been involved in generating and assessing measures. How do we make this a quicker process? We've been told over and over again, it takes 5 years and hundreds of thousands of dollars to get single measure into practice. How do we
Yes.
streamline this?
It's been such a long-standing issue. I wish I had an obvious answer for it. I think at there are a couple of strategies. I'll say first of is, I think there's often this concept that every time you need a measure, you need to start from scratch, right? Why does every measure require de novo development? So when I was at NQF, I suggested this model that never really came to be, but this concept of an incubator. Can we go out there and say, what are the measures all of us are using in practice, the health systems and others, that they use because they actually drive improvement? Why don't we start with those and start with measures we know work at some local site and then see what we can build on? So that's the first thing. I think the other one, and this is something I brought up, boy, even when I was at ARC, we were really like way ahead of the time, but I also think we need to start embedding measure development into our guideline development. If we think about, let's talk about measure development from the lens of a specialty society. If AGA is developing new IBD guidelines, isn't it sort of the perfect opportunity as you're updating that guideline to say, boy, what are the most important um, branch points on this guideline where if we measured it, we could significantly improve care? And do that. And in
Yeah,
fact, McMaster just came out with an article in the Annals of Internal Medicine a couple years ago that Eric Schneider and I wrote an editorial about, which was all about how do you embed measure development into guideline development. And I think there are ways to do that. And to me, it's a sweet spot for specialty societies because I think we're going to continue to do our guideline work. Can we just really strategically think about that, right? Think about your IBD guidelines. Where in that algorithm would you think about where a measure with logically exist? And then
yeah,
so much of this really comes down to and I know this is a later question, but so much of this comes down to our data ecosystem. If we actually have data available that gets longitudinal care, the ability to look at colon cancer screening over 10 years, the ability to really understand, you referred somebody, they got seen, or understanding somebody's long-term risks if they're on a biologic, and the role of, should the GI doc be immunizing patients like that who they know are at high risk, right? I just think these are ways we could think about it, when what I said to PTAC is I think in many ways the beauty of registries is that they're built by clinicians for clinicians, so
Yeah.
that those measures should be closer to the ones we ultimately that are meaningful, as you said, that could be used to drive improvement. So I guess in my dream scenario, you actually have the data you need to build measures that are meaningful, and you don't have to just, or you just collect all the data because it's available, and then you use your clinicians to help you determine which of those data we should make sure are clean and usable, and then move forward. So we have a new planning grant we've done with funds from the Moore Foundation with UCSF to 7 of our registries, for example, to come up with approaches of how to build diagnostic feedback into their registries, right? Use them to do something meaningful in that way. It isn't just about the measure. It's like, what are you learning as part of
Yeah.
that process of measuring and getting those data? And that's where I think it could be really exciting. One of my favorite examples is Iris, which is the eye registry, for example, has just an amazing amount. They have over, I think it's 20 outcome measures for every procedure built into the Iris registry. They provide benchmarks in near real time to their docs so they could see how they're doing. But what they do, that the next step we haven't even talked about, is if your performance is lower compared to your peers, it'll automatically have a button that pops up that says, you know what, you should do this CME program now. This is
Yes.
your rapid real-time microsite
Right.
learning for
Right.
you to learn what you're doing wrong. It's for you to learn to be better, not what you're doing wrong. Learn what you can do
Targeted
better.
education.
Exactly.
Yes.
That's the
Yeah.
power to me of having data and benchmarks brought to the clinic, brought to the clinician. And it's less about the bits and the bytes and the measure, and it's
Yeah.
more about what you're learning, what you're improving. And that's why I think, if you had a structural measure, and some of the boards have accepted this, for example, for part 4, if you have a measure that says you're in a registry and you review your quality measures compared to benchmark and target your education around that, that should be credit. That's a great structural measure, right?
Yeah.
Because it shows it's not just the measure. To me, it's about measurement and improvement. If you focus
Yeah.
on the measures, we get stuck and we get lost.
Well, I'd like to just summarize what I've just heard from you because I think it's critical. The guidelines should drive the measures. The measures should then feed into a data registry,
Yeah,
and the outcome of that data registry should then feed back us, I guess, whether our guideline was first place and whether it improved the outcome that it was designed to improve.
correct. And in a
So,
perfect world, to take that one step further, and I'm getting really out there, you would then have the feedback from this registry system back to your guidelines committee. So the next time you update it, you could see where
yeah,
there is
yeah,
and isn't
yeah,
adoption and what needs to happen.
yeah,
But we're not there, and we're still too far away from really truly getting to interoperability. But if you got to that point and the data are all available, then to me, it's less about the ultimate thing for me would be, especially society should identify those measures and those outcomes and figure out how to measure them, how to risk adjust them. But do they really need to always be the ones collecting the data? I don't know.
yeah.
I think that's an open question.
Ah, that's an interesting point. A third party could be the one that's actually collecting the data. Um, at the session you spoke at, we also had someone from Epic because we can't do this. I mean, the
No,
pitcher can pitch all the balls they want unless there's a catcher there with a big enough catcher's mitt to catch that ball. You're not going to have it. And
correct.
so we've got to figure out a way to get these EHR vendors to have common data sets. Um,
Totally.
otherwise we're never going to get there.
Yeah.
Helen,
And
as always happens, I have many more questions than we have time to discuss. But
shocking.
I'd love to. I think I got your vision here as to where you'd like to see measures ultimately go. Um, but if you had anything in closing, where
Yeah.
would you want where's your view? Where would you like the next generation of the Helen Burstins to focus to move this thing forward?
I just really feel strongly that we're not going to move forward unless we actually have a really high level of collaboration and coordination across primary care and specialty care. I'm tired of the battles of just don't do that, do this. Like, we should be, as a community, identifying what's appropriate, ensuring that happens for patients. Ensuring inappropriate stuff doesn't happen, but if the specialty community and the whole clinical community doesn't engage in this, somebody's going to hand us measures and measurement we don't like. We
Yeah.
should be making sure the data we care about are in the USCDI next version, right? It sounds wonky, but there's an opportunity for us to get closer to that vision of having the data we need available to get to the measures we hope would really drive improvement, be meaningful to clinicians, and also we haven't talked about it, but also meaningful to patients, because most of what we're giving them is just not that useful. But that collaboration and cooperation and removing that firing squad, that circular firing squad, again, between specialties around physician payment has to be something we've got to work towards.
Yeah, we talked before the recording here about nesting, and I think we're both talking about the same thing. We're all in this together,
Yes,
and we've got to be working for the benefit of the patients and
completely.
benefit to a population of patients, and that means we all have to figure out how we handle our own little nested solution inside
Absolutely.
population-based total cost of care models. Well, it's a lot of work to do going forward, but I hope we still have you doing it for quite a while to come yet. I know.
I hope so too. The
Yeah.
passion's still there, as you could tell,
Oh,
even
I can definitely tell.
after talking about this for decades and decades and decades. So all good.
Yeah.
But
Well,
thank you so much for inviting me. It was a fun conversation.
we could have talked for another hour. Thank you so much for being with us, Helen, and thanks to the audience for tuning in. You can access our podcasts on most all of the podcast platforms like Apple Podcasts, Google, Spotify, others. Learn more about the show on the programs page on healthcarenowradio.com. Lend your voice to the conversation on X at HC Now Radio, and be sure to follow us on Twitter at SonarMD. We're bringing patients, providers, and payers together to reimagine GI care. Until next time, I'm Dr. K. Stay well.